Hello, everyone.
Hello.
Hello.
Hi, Lindi. Hi, everybody. And welcome to the School of Public Health and Family Medicine noon meeting. I would like to introduce our guest today, Dr. Lindi Masson, who is a senior research fellow and head of the HIV Inflammation and Microbiome Working Group at the Burnet Institute in Australia. She also leads a research group in the Department of Pathology at the University of Cape Town, is an associate member of the Institute of Infectious Disease and Molecular Medicine, TUCT. She is also an honorary scientist at the Center for the AIDS Program of Research in South Africa and adjunct senior lecturer at Monash University in Australia. Lindi has been involved in HIV and genital microbiome and immunology research for 14 years. The primary focus of her research is to understand the factors associated with risk of HIV acquisition and adverse reproductive outcomes in women to develop tools to reduce this risk. As part of this work, Lindi is co-developer of the genital inflammation test, so-called GIFT, which is the topic of her presentation today, which is a low-cost point-of-care test that detects biomarkers of inflammation in women with asymptomatic infections who are at high risk of HIV and pregnancy complications. Lindi has contributed to 45 publications in international peer-reviewed journals and holds one international patent. Lindi is an Australian National Health and Medical Research Council investigator, award recipient, and her work is funded by grants from the National Institutes of Health, European and Developing Countries Clinical Trials Partnership, South African Medical Research Council Strategic Health Innovation Partnerships, and Australian Centre for HIV and Hepatitis Virology Research. So what else to say about Lindi? Quite an impressive CV. So Lindi, thank you very much for agreeing to present on the GIFT clinical trial that both you and I are working on. So I'm really honored that you have accepted my invitation to share with us today the basics of this clinical trial and where we're at the moment. And the title of our presentation is GIFT, Genital Inflammation Test for HIV Prevention and Reproductive Health. Lindi, this meeting is meant to finish at 1 o'clock. So please go ahead with the presentation, and then after that we will open the floor for questions, discussion, and any comments that participants may have. So thank you very much again, and you're welcome to share your screen.
Thank you so much, Adina, for that lovely introduction. Let me see. Can you see the presenter view? Is that okay?
Yeah, perhaps. Yeah, I can see. Well,
it's great, Lindi.
Okay, great. Okay, thanks. So as Adina mentioned, I'm going to be talking about the GIFT study today. So GIFT stands for Genital Inflammation Test, and the whole purpose of this project was to try and develop a tool to reduce risk of HIV infection and improve reproductive health in African women specifically. So today I'm presenting on behalf of the GIFT-Africa Consortium. And I first wanted to mention a couple of disclosures. So as Adina mentioned, I'm co-inventor on European and South African patents for this method for diagnosing an inflammatory condition in the female genital tract. And we're also recipients of funding from various funding mechanisms, including the EDCTP and the South African Medical Research Council. So this is the consortium. And I wanted to introduce everyone up front because everyone plays an absolutely critical role in this project. So the study is led by myself and Associate Professor Joanne Passmore, who's based at the University of Cape Town. Joanne actually supervised my PhD when we, and this is when we started our work on this project. And we've continued to work together ever since. And I recently moved to the Burnett Institute in 2019, but as Adina mentioned, I've maintained strong links with the University of Cape Town. So we have a large team at GCT, and this includes Adina and her team, Elise and Angela, who we've worked with for several years now on cost evaluations linked to the GIFT device and implementation of the GIFT device. There are also a whole group of project managers. Sabri is our commercialization manager, and also students working on this project at GCT. And then recently, with new funding from the EDCTP, we've managed to extend our team and include researchers from the Institut Pasteur in Madagascar, the Desmond Tutu Health Foundation in Cape Town, OFID, which is the Organisation for Public Health Interventions and Development in Zimbabwe, the London School of Hygiene and Tropical Medicine, UMC Utrecht, and the Institut Pasteur in France, as well as the Hitotsubashi University. And so all of these new team members are working on the clinical trial that will test our final prototype of the device, and also developing a strategy for implementing the device in South Africa and other resource-limited settings. So we started on this work some years ago, and it was really to address a problem that we'd identified in South African and other African women, where we saw that sexually transmitted infections, or STIs, and vaginal dysbiosis, which is an imbalance in the microbiome in the female genital tract, otherwise known as BV, or bacterial vaginosis. These conditions were highly, highly prevalent in our populations. And what we also found was that the majority of women who had these conditions didn't have symptoms. So we had this large pool of women who were asymptomatic. And in our setting, these conditions are only treated if women have a symptom and they go to a clinic to access treatment. And only a very small proportion of these women are actually symptomatic. So prior to this work, it was thought that this approach, called syndromic management, where you treat women according to clinical signs and symptoms, was really addressing the most severe of the infections. But what we actually found was that asymptomatic and symptomatic women had equivalent levels of inflammation in the genital tract. And this inflammation is in turn associated with very high risk of HIV infection. And it's also associated with serious pregnancy complications and infertility as well. So we wanted to find a way to try and identify, in a really inexpensive, easy to implement way, this large pool of women with asymptomatic infections. So before I go into the details of that, I just wanted to talk a bit more about syndromic management and why this is the current standard of care in South Africa and other resource-limited settings. So it was implemented by the WHO in the early 1990s, and it's actually since then been revised. I think we had new guidelines released in 2021, and they really haven't changed very much, because ultimately we just don't have any low-cost alternatives to syndromic management. All of the STI and BV diagnostic tools are far too approach. It's relatively easy to implement. You don't need lab facilities, experienced staff, or specialized equipment, and patients are given immediate treatment. And this is really important, especially in our context where the return rates are often very low. However, as I mentioned, most women, actually over 80%, has been found in some studies, are asymptomatic. And there's also frequent overtreatment, because you have to just treat it according to a general syndrome of vaginal discharge or something similar. And this discharge could be caused by a number of different infections. So this is a modeling study that was conducted by Lee Johnson, also based at GCT, and they looked at the effect of syndromic management on the prevalence of sexually transmitted infections. So they looked at the change in the prevalence between 1990 and 2006, and they found that while there was an impact on infections that cause genital ulcers and are treatable or curable, like chancroid and syphilis, genital herpes is not curable, so there was no impact there. However, there was very little impact on the discharge-causing infections like gonorrhea, chlamydia, trichomoniasis, and bacterial vaginosis, as well as vaginal candidiasis. So we chose to focus on these discharge-causing STIs and bacterial vaginosis to try and develop a tool to improve the management of these conditions. So as part of this process, we've done a thorough investigation of the alternatives to syndromic management. And the alternatives range in cost and accuracy. And you can see here that syndromic management is right at the bottom. It's the most inexpensive approach, but it's also not very accurate. There are other clinical tools like AMSL criteria, where they look at the presence of clue cells, which are epithelial cells in the genital tract that are coated with non-optimal bacteria. So they look at this by microscopy, and they also look at things like odor and take into account symptoms as well. So AMSL's criteria performs pretty poorly as well. Over the years, there have been a lot of different groups that have developed different antigen point-of-care tests. So simple lateral flow-like tests, like a pregnancy, over-the-counter pregnancy test. However, although these don't cost very much, they're also not very accurate today. Unfortunately, the majority of the sexually transmitted infections that we look at are present at very low levels. They don't need to be very abundant in the genital tract to cause significant pathology. So they're not abundant enough to be detected by these point-of-care tests. There is, however, one exception, and that's the OSOM trichomoniasis test, and that's performed really well and also is quite inexpensive. And that's a point-of-care test. Then we have microscopy to look for bacterial vaginosis. This is considered the clinical gold standard at the moment, although there are a lot of new molecular tests for bacterial vaginosis that have been developed recently and are currently being evaluated. And then there are a whole lot of laboratory and near point-of-care nucleic acid amplification tests. And these are all highly, highly accurate. They really are the gold standards in the field, but they're also very costly. You need expensive equipment. Each test for each specific STI can cost around 400 Rand. If it can't be done on site, then you need to take into account transport and also having the technical technically experienced personnel to run these diagnostic tests. So when we were thinking about an alternative, we really wanted to find something that would be low cost, much lower cost than these nucleic acid amplification tests, but also have sufficient accuracy to identify the woman with these inflammatory asymptomatic infections. So that was the aim of the study, to try and find a way to reduce the risk of HIV infection and improve reproductive health in African women by developing a tool to identify asymptomatic sexually transmitted infections, or dysbiosis, otherwise known as bacterial vaginosis. And so we've been working on the study for a few years now, since I think 2010. And I've described how we identified the problem. We then went on to conduct a biomarkers discovery study. We validated those biomarkers. We partnered with a biotech company to develop a prototype point-of-care test. We also partnered with Adina and Angela and Elise to conduct our cost, budget impact, and cost effectiveness studies. And then we have evaluated the first prototype clinically. We've also developed our own antibodies that we'll use in the next version of the prototype. We've currently have a new biotech partner who's developing the final optimized device. And we've also started on acceptability and user experience studies. And we'll be conducting a prototype validation trial. And this will involve 3 clinical sites in Zimbabwe, Madagascar, and South Africa. And then after this, the UCT RC&I team will be doing the pre-market testing, and we will conduct a registered trial as the final stage. So I wanted to show a bit of the data from our biomarkers discovery study first. So this data was collected from samples collected from women from Durban, South Africa. And these women were screened for the common STIs and bacterial vaginosis that we're interested in, chlamydia, gonorrhea, trichomoniasis, BV. They were also screened for herpes simplex virus reactivation in this study. And we also measured a range of different pro-inflammatory cytokines, chemokines, as well as other cytokines with different functions. And we looked at the overall cytokine profiles in these women. So on the y-axis, the cumulative standardized beta coefficients are shown. And so each section of each bar represents the relationship between each cytokine and each STI after adjusting for co-infections. So you can see here that with the size of the bar indicating the amount of inflammation, that chlamydia and gonorrhea caused substantial amount of inflammation, followed by trichomoniasis and bacterial vaginosis. So we saw really strong associations between these cytokines and these STIs and BV. And so we wanted to look to see if any of these cytokines could maybe be used as biomarkers. And so we did some logistic regression modeling and found that a combination of 3 of these cytokines, interleukin-1 alpha, interleukin-1 beta, and IP-10, that's interferon gamma-induced protein 10, these 3 cytokines was the most accurate combination of biomarkers that identified women who had any one of these sexually transmitted infections or BV. We found that there were no cytokines that differentiated between the individual infections or BV. So most of the infections, or they all caused a certain amount of inflammation. And so it was a non-specific indicator of a syndrome of inflammation caused by any one of these infections. So we found that in HIV-negative women, these biomarkers correctly classified 76% of women. In HIV-positive women, they correctly classified 84% of women. And this was a substantial improvement compared to clinical signs and symptoms. So signs and symptoms only classified 46% of women correctly, and actually only picked up 19% of the women who had one of these infections or BV. So we then went on to conduct biomarkers validation studies across different cohorts and sample types. So this data includes women from the original study in Durban, South Africa, as a comparator, the Caprisa 002 study. It also includes women enrolled in the cohort study that Joanne ran in Cape Town and Soweto in South Africa, the WISH study, or the Women's Initiative in Sexual Health study, and the FemPrep clinical trial, which enrolled women in Bondo, Kenya, and also in Pretoria, South Africa. So we measured the same biomarkers in all of the studies, and we also measured the biomarkers in different sample types, because we really wanted to try and identify the best sample type for biomarker measurement that was most accurate, but could also be most easily collected, or potentially even self-collected. So we compared cervicovaginal lavages, which is a saline wash of the vaginal vault that's then retrieved, and then your cytokines are measured in that sample. so it's a bit more difficult to collect. Menstrual cups samples. Menstrual cups are used by women during menstruation to collect menstrual blood. So we use those instead to collect genital secretions and measured the cytokines in those samples. And then we also looked at vulvovaginal, lateral vaginal wall, and endocervical swabs. So we found that across all of the sample types, the biomarkers performed really consistently. And we identified the lateral vaginal wall swab as the best sample type for biomarkers measurement. And this sample is very easy to collect and can be self-collected. And then we wanted to see if any other factors or variables could improve the accuracy of the biomarkers. Excuse me. And we actually found that if we measured vaginal pH as well, we didn't need to measure all 3 cytokines. We could just measure one inflammatory marker and improve the accuracy of the model and correctly classify 82% of women. So IL-1ɑ and vaginal pH performed best across these studies. We also collaborated with Heather Jaspan and Katie Leonard at UCT to look at some microbiome data and see if we could explain why some women had inflammation and were picked up with these biomarkers, even though they didn't have an STI or bacterial vaginosis. So in our studies, bacterial vaginosis is diagnosed using microscopy, but you can get a lot more depth and greater sensitivity if you do a 16S rRNA gene sequencing analysis. And so we looked at data generated by Heather and Katie to see if the women who were picked up by the biomarkers but didn't have one of the STIs or BV maybe had dysbiosis that we were missing using these tools. And we found that this was the case. So the women who were considered false positive actually did have an increased abundance of non-optimal bacteria that could potentially be causing this inflammation. So this means that if we considered this kind of molecular data, as well as the other clinical data, diagnostic data for STIs and BV that we're using, we would potentially increase the accuracy of the biomarkers algorithm even more. So then I wanted to show some of the data from Adina and Elise and Angela's work. So we partnered with Adina and her team to firstly do a cost and budget impact analysis, and then Elise worked on this cost effectiveness analysis. So Adina can probably explain this, or Elise, a lot better than me. But what we did here was we compared different interventions to syndromic management. So we compared using the GIFT device to pick up women with inflammation and then directly treating them, that's the second row, to picking up women with inflammation with GIFT and then sending them on for further diagnostic tests to identify exactly which STI or BV they had. Then we looked at laboratory STI testing, and then we looked at near point of care STI testing. And what we found that was that GIFT followed by immediate treatment was by far the most cost-effective approach, with an incremental cost-effectiveness ratio of only 5.88 compared to over 50 for laboratory STI testing and over 75 for near point of care molecular STI diagnostics and microscopy. So I wanted to also show some examples of our first prototype devices. So these are the lateral flow tests, and you basically load the sample into this loading well here, and the sample runs across this nitrocellulose strip. And if a test line comes up here at the bottom, then the woman would be considered to be positive, and we also have a control line to show that the test ran well as well. And so with these first prototypes, we were really relieved to see that we could actually visibly see when women were positive using these lateral flow tests. And this was important because these cytokines are present at nanogram concentrations in the genital tract. So to be able to visually see a band with this kind of simple readout format was really exciting for us. So when we looked at the accuracy of these devices, and we had a device for IL-1 alpha and a device for IL-1 beta, we compared the accuracy to ELISA, which is the gold standard for cytokine measurement. We found that the devices were very sensitive, so they picked up the majority of women who had IL-1 alpha or IL-1 beta above our established cutoffs for these cytokines, but they were relatively non-specific. So there were lots of false positives. And this is largely due to the design of the devices. So here we tried to have a test where you could just have a band if a woman was positive, but the band would be absent if the woman was negative. But because these cytokines are always present in the genital tract, it looks like we need to find an alternative approach. So what we're going to be doing now is including a reference line or a reference chart. So you'll look at how dark the band is relative to that reference line or reference chart, and from there be able to determine if the woman is positive or negative. So with our new funding from the EDCTP, we're now working on optimizing the device. We're then going to evaluate the device in 675 women. As I mentioned, this will be done in South Africa, Zimbabwe, and Madagascar. And then we are working on user choice experiments. We are, well, the Royal We, so the London School has developed an amazing Delphi questionnaire, and they're busy collecting data from key stakeholders in the field, and basically is collecting information about how and where the device should be implemented. We'll also be conducting discrete choice experiments. There'll be some mathematical modeling to determine the best implementation algorithm. And then Adina and Elise and their team will be doing the economic evaluation. And then after that, we'll be doing the pre-market testing with RCNI, and then we'll conduct the registered trial. So also briefly wanted to mention future work and future diagnostics. So we've also been expanding on our work looking at inflammatory cytokines as biomarkers to try and measure a lot more different proteins in our female genital tract samples, and try and improve on the biomarkers that we currently have. So we've been using metaproteomics to do this, and we did this analysis in the WISH cohort of women that was run by Joanne Passmore, and we analyzed the samples using mass spec and collected data for over 3,000 proteins, and these included human, bacterial, and fungal proteins. And then Bahia, who's doing a PhD in my group, and Aria, who's an amazing bioinformatician who we collaborate with in the US, they worked on a whole lot of different approaches for identifying the best biomarkers for different conditions, and they looked at all of the different sexually transmitted infections, and they also looked at bacterial vaginosis, or BV. And although we didn't find good biomarkers for the STIs, we found really good biomarkers for BV. So we had data from 2 different study visits, and Bahia and Aria used different machine learning approaches to identify the most consistent biomarkers across multiple methods and also across both of the study visits. And we found 2 proteins that were shared across all of these different methods and visits. And I can't mention the proteins because we're busy filing a patent for this work. but these proteins were very, very accurate for classifying women according to BV status. So the accuracy was 93% for the one and 96% for the other protein. So we're hoping that this kind of tool would be useful to be included as part of our GIFT algorithm, where women with inflammation are identified, and then women who have BV can be directly treated for, and specifically treated for BV. So this is how we envisage GIFT being implemented. So we think it would be best suited for use in family planning or antenatal clinics, where women can come in. They can either self-test, or the test could be nurse administered. And then from there, we will identify the women who have inflammation, which is most likely caused by an STI or BV. And what we're working on now is a context-specific management algorithm. So it's possible that not all algorithms will work or be as fitting for different settings. But what we're looking at things like, we're looking at including the GIFT device in the existing syndromic management algorithm. We're looking at including the device with things like risk scoring, possibly including it with other tests like the OSOM TV rapid trichomoniasis rapid test that I mentioned, or our new BV biomarkers test as well. And you could possibly screen with the GIFT device and then send the woman for further etiological testing using near point-of-care nucleic acid amplification tests. And so the economic evaluation and the user experiments and the modeling studies are absolutely critical for informing the algorithm, the management algorithms that we develop in the future. So there are a lot of different people to thank. I wanted to firstly thank the participants of all of the studies that have been included in this work. I wanted to thank our whole GIFT-Africa Consortium, as well as all of our collaborators who've contributed over the years, and also all of our funders. Thank you.
Thank you very much, Lindi, for this very interesting and quite exhaustive presentation. I must say, you've learned a lot. I've learned a lot too. And I hope that also everybody else who joined this meeting have found this quite an interesting and very relevant work. I must say, I'm very excited about it all. So thank you very much again. So we'll open the floor for the audience. So if anybody has any question or comment to make, please go ahead. What causes perianal ulcers? Hold on, let me just check in the chat box. There is a question from Tafadzva. What causes perianal ulcers, non-infectious and have no viral infection after biopsy test in HIV-positive men and on ART? Surgery has or had to be used as means of treatment. Could you shed some light on that? Quite an interesting question. Thank you.
Yeah, thanks very much for that question. I mean, I think the short answer is if it's not infectious, then I'm not sure. I mean, I can think of a variety of different viral infections and things like syphilis that could cause that. But yeah, I mean, I just wouldn't know about non-infectious ulcers. Sorry, I can't answer your question.
Thanks, Lindi. Okay, and Tiki, please go ahead with your question.
Thanks, Lindi. Can you hear me?
Yes.
Okay, all right. Thank you for that interesting presentation. So, I mean, I have not been in a cytology laboratory for a few years now, but when I was still active in that space, a lot of postmenopausal women, I guess I'm sensitive to that now because I'm also postmenopausal, presented with bacterial vaginosis. So, I mean, just based on your presentation, I'm assuming that your study participants were in their reproductive ages, because you mentioned that, the infections had an impact on their reproductive health, but I'm not quite sure, I'm speculating. And if that is the case, understanding, I mean, the prevalence of HIV, that it's not limited, to women of a certain age group. And we know that increasingly, postmenopausal women are also getting exposed. So what I would like to know then is, in that instance, what provisions will be in place, for those women who are in that bracket, if they are not included in your study?
Thanks. That's a great question. So yes, so all of the women that have been included in our studies to date have been reproductive aged women. Although in the first Biomarkers discovery study, we likely had some perimenopausal women as well. I completely agree with what you're saying, where I know that postmenopausal women have an increased occurrence of BV, and that's thought to be because of the decreases in estrogen levels, which is linked to glycogen production, which then is a great food source for the healthy, optimal lactobacilli. So your question is something that's actually going to be addressed as part of our Delphi questionnaires, where we've kind of stratified women by different age groups, and we're asking the stakeholders where they think GIFT would be best suited. So, whether or not to focus on young women where we see the highest rates of HIV infection and sexually transmitted infections as well, or to expand that to older women and possibly postmenopausal women as well. I think at the moment, a lot of our work focuses on the young women, and really that is where we see just the most high rates of HIV infection. So I think if GIFT is something that's too expensive to be implemented or to be offered to all women, then we might, because we're thinking of we're wanting to partner with government, and we want this to be offered by the Department of Health and in the government healthcare sector. If it's too expensive to be implemented for all women, then maybe we need to focus on the women where we see the highest rates of these infections. So that's kind of been our thinking. And also the women who are tend to have multiple partners and are not in stable relationships, and there are all of those factors to consider. But it's not really a decision that we can make, and that's why we're engaging with policymakers and stakeholders in the field, so that they can really inform this decision based on their experience. But what we also want to do is not only offer this, in the government sector, but also potentially offer this test at pharmacies where women can self-test and monitor their genital health, and then if they pick up high levels of inflammation, then they can potentially go and see a healthcare provider. So we are thinking of lots of different potential strategies, but that's really a kind of a work in progress at the moment, but a really, really great point.
Thanks, Lindi. Any other questions? I'm also aware of the fact that this meeting is being held in person as well. Okay, there is a hand up. Katleho, please go ahead.
Hi, I'm actually in the, So
You're echoing. Are you in the car? Driving? Okay, we lost Katleho.
Okay,
Hopefully she'll come back.
Hi, can you hear me?
We can hear you, but not that clearly. Go ahead, please.
So I just have a question. Great presentation, by the way. So I just wanted to find out that there are research priorities that are often set by academics in the pharmaceutical industry. However, are these groups best placed to ensure that the resources for research are focused on the clinically relevant and meaningful issues for clinicians and patients in terms of your research?
I'm sorry, I couldn't hear the last part. Could you repeat that, please?
Sorry, I was saying that, okay, can you hear me now? Okay, so is the research best placed to ensure that resources are focused on clinically relevant and meaningful issues for clinicians and patients?
Did you hear it?
I
couldn't.
So are the I think Lego was asking about
Okay.
Sorry, focusing on clinically relevant conditions and the resources that we're using. I'm sorry, it wasn't entirely clear. So I think, I mean, if you look at I'm going to try and answer it to what I think you're asking. Maybe that, you know, whether all of this funding that we're spending is being utilized for, you know, the real key clinically relevant conditions in the setting. Is that right?
Yes.
Okay. Yeah, so I mean, I think a lot of our earlier work really informs this. And I mean, I think that is a really important consideration. Work from Lee Johnson's group has shown that a huge proportion of new HIV infections in South African women are attributable to other sexually transmitted infections and bacterial vaginosis. So BV alone increases a woman's risk of HIV 4.4-fold, over 4.4-fold. So that's BV alone. All of the other STIs increase the risk by over 2-fold each. So if you think about the number of infections, HIV infections that can be, you know, directly explained by these conditions, then I mean it's absolutely critical that we address them. As far as cost goes, you've got to consider the lifelong antiretroviral treatment and the massive budget impact that has. So if you can avert just a small proportion of HIV infections by treating these risk factors, then you can, you know, dramatically reduce the cost of antiretroviral therapy. And that's just with HIV. So preterm birth accounts for, you know, a huge social burden and has a huge impact on the economy as well. And the cost of looking after just one preterm infant in ICU is astronomical. So if you can reduce the rates of preterm birth, neonatal sepsis, maternal sepsis, you can also have a massive impact on those budgets as well. So, I mean, it may not seem that important to improve treatment of you know, these common STIs and microbiome dysbiosis, but the impacts that they have, both social and economic, are massive.
Thanks, Lindi. I hope that, yeah, Kathel is saying thumbs up. That was the question. So thank you for explaining to her about particularly the resources and the target population. There is a comment from Virginia. It would be amazing to have something in the public sector. I used to work in an STI clinic in Johannesburg and felt that we overtreated women with discharges. Everyone got gonorrhea treatment and ulcer treatment. but nothing for anything else, and they probably needed other treatments.
Yeah, I mean, I completely agree. So, I mean, a lot of our focus has been on the asymptomatic women, so not the women that you would have been treating, Virginia, but we are looking at seeing whether, you know, we incorporate GIFT in the syndromic management algorithm. We can try and inform on the treatment that's offered, and try and reduce the amount of overtreatment as well. So right now, a lot of decisions are also made based on kind of risk profiling, like the age of the woman, and, you know, whether they have partners, multiple partners, or partners with STIs. But if we can have a non-subjective way of improving those decisions, then hopefully we can try and avoid some of that overtreatment in that context as well.
Yeah. Simpy, well, thanks for clarifying. Thanks for helping. Then a question for, has culture been an issue in your project? And if so, how did you dealt with it? A good question. How do you deal with it? Still very much the case, yeah. During the clinical trial. Yeah. We'll probably have that as an issue, yeah. What were your experiences, or what, Lindi, yours from the previous study in South Africa?
Yeah, so I mean, so no, in the previous studies, it hasn't really been an issue. So the populations the women included in these studies were of, you know, various different cultural backgrounds, and all were very willing participants of the studies, and very willing to have the vaginal swab samples collected, and I think it's something that we probably should have addressed in more detail early on, but it is part of the next phase of the study. So we're expanding beyond South Africa now, and the study, as I mentioned, will be enrolling women in Zimbabwe and Madagascar as well. And as part of those cohort studies, our collaborators at the London School will be conducting detailed user experience and discrete choice experiments to try and get a better understanding of how the woman would feel about utilizing this device, and the way that the testing is done as well. And, you know, would they prefer self collect the swabs, or do they prefer it if the clinician collects the swabs, and all of those kinds of like really, really critical issues. So we hope that we're going to get a better, you know, representative idea of any cultural factors that might affect the implementation of GIFT, and also the way that it's implemented. But yeah, a very, very critical question, and we probably should have started the study with that kind of work. But we're learning as well as we're going on, and you know, we're really excited for that work to inform our strategies going forward, and also our future work with future diagnostic tests.
Thank you, Lindi. I'm aware that the meeting is also being held in person, so I'm not sure how we're dealing with questions and comments from that part of the audience, if there are any people attending in person. So Simpy, do you know, are those people also putting their questions in the comments in the chat box, or is there any other way we can see if there are any questions from them? Perhaps everybody if anybody's attending in person, they have their computers, they have probably also logged in. Okay. All right. So just checking if there are any more questions. Some of these questions are really, really pertinent and something that we need to definitely think about as we go along. I'm very excited about this trial, Lindi. I think it's going to be really an eye-opener, and also potentially huge opportunity to avert many of the infections, HIV as well as other sexually transmitted infections, and available in the public sector, as well as save lives and also the suffering through obviously sexually transmitted infections and HIV. So the test has a great potential, and as we've seen in the paper that we published in Sexually Transmitted Infections from our South African project, that resources could be redirected elsewhere. The resources saved by averting many cases of these infections could be then redirected elsewhere, and women would not be put on unnecessary treatment and also treated more accurately. So we're very excited about it all, and we're hoping that we will have some really exciting findings from the trial, and that we will have another opportunity, Lindi, to present something maybe in 2 years' time or so. I will invite you back to the to the group, and then we can share some of our findings. But if there are no any other questions, we almost close. It's 8 minutes to 1. If there are no questions and comments, then I would like to thank you all for attending the meeting, and very much appreciate your time, really, Lindi, for I don't know what the time is in Australia, but maybe getting ready for dinner.
Not too late.
Okay, all right. So time for you to go to bed. So I really, really value your time and your willingness to share this with us. So thank you very much. And everybody's saying thank you very much. Informative, excellent presentation.
Thank you so much, everyone. Thank you for your time, and thank you so much for the invitation, Adina. It's been great working with you so far, and I'm so glad we can continue with this collaboration.
So thanks.
And I look forward to seeing you soon.
Wonderful. Thank you. And bye, everyone.
Bye.
Take care.
Bye.
Cheers.
Ciao.